Okay, in our video series of neurology lectures, in this video, we are going to talk about Alzheimer's disease. We are going to talk about its clinical presentation, the causes, the diagnosis, and management of Alzheimer's disease in detail. On November 5th, 1994, former US President Ronald Reagan sits on his desk, takes a piece of paper and a pen, and writes down, "I now begin the journey that will lead me into the sunset of my life." He makes a shocking revelation to the world that he is suffering from Alzheimer's disease. Once a powerful president, now is helpless in front of Alzheimer's disease. What is Alzheimer's disease? How does it present? Today we are going to talk about that. Alzheimer's disease is a progressive neurodegenerative disorder characterized by gradual decline in memory, cognitive function, and behavioral abilities, ultimately impairing the daily life and independence. Alzheimer's disease is the most common cause of dementia. 70% of the cases of dementia are due to Alzheimer's disease. These patients of Alzheimer's disease have so much forgetfulness and memory loss that they forget their own relationships, they forget their wife, they forget their children, they forget the normal functioning of life, they forget how to drive. If they were expert in playing piano, now they cannot do that. These patients have memory loss to an extent that they cannot speak now, therefore they are sitting silent on the side, and in the later stages they have memory loss to an extent that they forget how to button up the shirt, how to wear clothes, and they're dependent on others for the daily life activities. In the very last stages, these patients have memory loss to an extent that they cannot eat, they cannot take the food, and they become dependent on others on eating. So this is a progression of Alzheimer's disease where there is severe forgetfulness that this impairs the daily life and independence of the patient. It is the leading cause of dementia, and females are more commonly affected as compared to males. The causes of Alzheimer's disease are yet not known to the world, but it is most commonly due to the genetics. It runs in families, and in the genes, amyloid precursor protein gene is involved. How does amyloid precursor protein gene affects and cause Alzheimer's disease? We are going to talk about that, but for now remember that amyloid precursor protein gene is present on chromosome 21, and in which condition there is trisomy of chromosome 21. There is trisomy of chromosome 21 in Down syndrome. Therefore, Down syndrome patients are most commonly affected by Alzheimer's disease, and there is early onset dementia. There is early onset Alzheimer's disease in Down syndrome patients around age 50. They start developing Alzheimer's disease symptoms because they have three chromosomes at chromosome 21. Therefore, there is increased chances of this gene mutation. They have early onset familial Alzheimer's dementia. These patients will have family members who had developed dementia, and this gene is responsible for causing Alzheimer's disease. Other than amyloid precursor protein, presenilin 1 and presenilin 2 are involved. Apolipoprotein E, especially apolipoprotein epsilon 4 type, is involved in late onset Alzheimer's dementia. So these are the important genes that you need to remember that can cause Alzheimer's disease. Alzheimer's disease has a very important genetic factor. Among the risk factor that can predispose a patient to develop Alzheimer's disease, age is the biggest risk factor. In exams, if they ask you what is the biggest risk factor, you have to tell them age is the biggest risk factor. More elderly patients are more prone to develop Alzheimer's disease. If there is a family history, it is a very important factor. It is the biggest risk factor for early onset dementia. If a patient has a family history of Alzheimer's disease, there is a chance that there will be early onset dementia in that patient. Diabetes, hypertension, obesity, and dyslipidemia disturb the normal functioning of the brain and vessels. Therefore, they can contribute to Alzheimer's disease. Traumatic brain injury has been associated with Alzheimer's disease. Sleep deprivation and abnormal sleep patterns, especially in our generation, this is a very common risk factor for Alzheimer's disease. Another important point is that low socioeconomic status and low educational status can also cause Alzheimer's disease. Now, why would low educational status cause Alzheimer's disease? Basically, a person who is educated and keeps studying throughout his life, there is increased stimulation of the neuron. Therefore, the neurons get more resistant to this type of degeneration. While the people who are not educated, there is less stimulation of neurons throughout the life. Therefore, there is increased chances of degradation of neurons and development of Alzheimer's disease. Now, coming to the pathophysiology, in the brain there is accumulation of abnormal proteins in Alzheimer's disease. That abnormal protein can be accumulated extracellularly outside the neurons in the brain, or they can be accumulated within the neurons intracellularly. Now, coming to the normal neuron structure. In the normal neurons, we have these brain neurons that are lying in the brain, and this is the extracellular matrix. This picture shows the normal brain cells. Now, in this picture, you can see that there is abnormal deposition of amyloid plaques. What are amyloid plaques that are depositing in a patient with Alzheimer's disease? Amyloid plaques are basically amyloid precursor proteins that are broken down by beta secretase and gamma secretase enzyme. These enzymes degrade the amyloid precursor protein, and the garbage and the degradation products are A beta peptides. These A beta peptides accumulate as amyloid plaques, and this accumulation of A beta peptide in the form of amyloid plaques causes Alzheimer's disease. And this happens in the people who have that amyloid precursor protein gene mutation that we talked about. And this occurs extracellularly outside the cells. Now, coming within the cells, neurofibrillary tangles are formed. What are neurofibrillary tangles that are formed inside the neuron cells and cause Alzheimer's disease? Basically, these are tau proteins. Tau proteins are microtubule proteins, and these tau proteins get hyperphosphorylated and they form neurofibrillary tangles. These neurofibrillary tangles accumulate within the neurons and they damage the neuron, resulting in neurotoxic effects and Alzheimer's disease. So, in the brain, extracellularly, amyloid plaques were accumulating. These are also called as senile plaques or neuritic plaques, and they accumulate in the gray matter, and these are basically A beta proteins. And they have neurotoxic effects. The garbage that was accumulating extracellularly, amyloid plaques. Intracellularly, there are neurofibrillary tangles that are basically hyperphosphorylated tau protein, and they have neurotoxic effect. Therefore, this is the pathophysiology that results in Alzheimer's disease. In the treatment and management, what we try to do is that we reduce the deposition of these neurofibrillary tangles. Now, another important part of pathophysiology in these patients is that these patients have reduced cholinergic stimulation. Remember, acetylcholine has stimulant effect in the brain. In the brain, cholinergic stimulation is reduced in patients of Alzheimer's disease. Less acetylcholine leads to less stimulation and cognitive decline in these patients. Now, in the treatment of Alzheimer's disease, what we will try to do is that we will try to increase this acetylcholine. Therefore, understanding the pathophysiology is very important. Whenever you are studying medicine, it's very important that you properly understand the pathophysiology. When you thoroughly understand the pathophysiology, you can easily tell the symptoms the patient can experience and the diagnosis that you will make, and how will you correct that abnormal pathophysiology in the brain. Now, coming to the clinical presentation of Alzheimer's disease. In the clinical presentation of Alzheimer's disease, these patients have short-term memory loss. These patients have episodic memory loss initially, while sometimes they experience memory loss, and later on it progresses to a permanent memory loss that is present all the time. Now, these patients have short-term memory loss in the sense that when you sit with them and you have a discussion with them, you tell them that I am Dr. Vakas and I am here to discuss about the problem that you might be experiencing. After some time, after 3-4 minutes, they will forget that they are in a hospital and who they are talking to. That the doctor is sitting in front of me. They totally forget that, and they once again ask that who is this person that is talking to me. So you will tell them again that yes, I am doctor and I am discussing about a problem that you might be experiencing. They will be like, okay, and after some time they will again ask, who is this guy I am talking to, and where am I? So this level of memory loss takes place in these patients. These patients have memory loss to an extent that the path that they have been treading for their whole life, like the path from their house to the grocery store, they go out to the grocery store in the very familiar spaces, in the very familiar streets. They get lost. They keep roaming around their house the whole day and they cannot find their house. So this is the extent of memory loss in these patients. These patients also experience language impairment. In the language impairment, it occurs in the sequence that initially they have impaired naming. They forget the names of the things. For example, if they want a glass, they will say, give me that bottle. If they see a cat, they will say, this is a dog. So they will have impaired naming of the thing and they don't even realize that they are saying it wrong. In my previous video on dementia, I discussed that what is the difference between the memory loss that occurs in normal aging and what is the memory loss that occurs in dementia patient. In normal aging, patient will have the insight, patient will know that I have forgotten the name, and he will try and struggle to remember that name. But in patient with dementia, that patient will have loss of insight, and that patient won't even know. That patient will be totally unconcerned that he has forgotten the name and he is using the wrong word for a thing. So that is the difference between normal aging and dementia. If you want to know about that, make sure to check out my previous video on dementia introduction. Then there is impaired comprehension. Whatever you tell them, they cannot comprehend that. They will act like they will nod in front of you, but they won't understand anything whatever you are telling them. Then they have impaired fluency. As soon as they start forgetting the language, they don't even know how to speak. Therefore they will be speaking less, they will be depressed, they will not be saying a lot of things other than the episode of aggressions and agitation that they experience. Most of the time they will be silent and they will not be saying a lot of things because there is impaired fluency in these patients. Then there is temporal and spatial disorientation. They slowly and gradually lose the spatial orientation, in the sense that, let's say, if they are driving a car, they won't even realize, and they will have collided their car with a light pole, or they have collided their car with another car, and they don't even know that they have to drive the car in a specific lane. This level of dementia takes place in these patients, and they will be totally unconcerned after that accident. They will be walking on a certain park route throughout their life, but they will get lost in the very same path and they won't be able to reach back home. This is a very common presentation that you would see, that the family will bring these dementia patients and they would say that our father was experiencing forgetfulness, but we thought that this is normal aging process. But this time when he went out of the house, he was roaming around in the same neighborhood trying to find the house, and he was unable to find it. Now this is concerning because this is dementia. In normal aging patient, if he forgets something, he would try to recall for some time, and then he is able to recall that, okay, that's the location of my house. And specifically if he is in a familiar space, then there is a very less chance that he forgets that, even till death. In dementia, they forget the very familiar spaces that they are living in. These patients have impaired judgment and executive function. These patients cannot execute a plan. For example, if they are going out to the grocery to buy a thing, planning out the things, making a list of those things, then taking the car out and going to the grocery store, picking up the thing and going to the counter for the payment, they totally forget how to do that. They may be picking up the bag and going ahead that we are going for shopping, we are going for grocery, but they won't be able to execute each and everything properly. They will be lost in the process. Even when they are speaking, they are lost in the process of speaking. They are speaking one thing and then they are moving ahead to another thing. These patients will experience apraxia. When you tell them to do a certain thing, like picking up a pencil from the desk, they will listen to it, they will nod, but they will not do it because they don't even understand. They have this receptive aphasia where they don't understand the command and they don't know how to execute that command. Even to the very basic things, Alzheimer's disease affects the patients. In the later stages, they won't be able to button up their shirt, they won't be able to wear the clothes. This is apraxia. These patients also have agnosia. Agnosia in the sense where they cannot comprehend a thing. For example, if you show them a bicycle and you tell them that what is this thing, then they will be lost in the process and they will be thinking and they won't be able to get anything out of it. Maybe they might tell that this is the tire, this is the pedal, this is the seat, but they won't be able to tell that this is a bicycle. That is agnosia. Alexia, where they are unable to read a certain thing, even their own handwritten things. The most educated people, when they develop Alzheimer's disease, when you show anything written in front of them, they cannot comprehend that. That is alexia that occurs due to Alzheimer's disease. These patients also experience behavioral problems. In the initial stages, they have this depression where they are sitting at a corner of the room. They won't say anything to any person. But in the later stages, they get more aggressive and agitated. They have this mood disorder, symptoms of depression. In the later stages, they get urinary incontinence. In the initial stages, they maintain a normal social demeanor, they maintain a normal facade. You won't be able to see that that patient has Alzheimer's disease. They will be sitting in a park, they will be sitting normally, and even if you say hello to them, they will nod their head and they won't say anything, and you will feel like this old man is here for an outing in the park. But these patients have Alzheimer's dementia. In the later stages, the normal social demeanor is lost in these patients. These patients develop urinary incontinence. These patients don't know how to wear clothes. These patients don't know how to eat food. And it also affects the entorhinal cortex, resulting in hypoosmia, where they're unable to smell things. And in the later stages, these patients can also experience insomnia. Patients of mild to moderate Alzheimer's disease maintain a normal social demeanor and continue performing some daily life activities independently. But in the later stages, these activities are also lost. So, in the initial stages, patients will have this memory loss, but they will be sitting normally, comfortably, and they will act like there is nothing abnormal. Even if you say hello to them, they might say hello. But in the later stages, everything is lost. Now, coming to the diagnosis of Alzheimer's disease. In the diagnosis of Alzheimer's disease, there is no single specific diagnostic test. The only test that can give you a definitive diagnosis that this is 100% Alzheimer's disease, that is post-mortem brain biopsy after the death of the patient, which is very rarely done. And this post-mortem brain biopsy would show amyloid plaques and neurofibrillary tangles in the brain. But an approach that we can use in these patients is that we can do clinical evaluation, cognitive testing, neuroimaging, scans of the brain, and some biomarkers in the CSF as well as in the blood. Now, I'll be talking about each one of these to help you make the diagnosis of Alzheimer's disease. Now, whenever you suspect that a patient is having dementia, the first thing in clinical evaluation is that you take thorough history from this patient to differentiate that whether this is normal aging loss or this is memory loss due to dementia. You do thorough neurological examination to rule out any pathology like cerebrovascular accident. You rule out pseudodementia and delirium. What is pseudodementia? I will explain it in detail in my introduction on dementia video. Pseudodementia occurs due to depression, where the patient are experiencing depression, and that depression causes memory loss. But as you treat the depression in old patients, the memory loss goes away. So that is called as pseudodementia, dementia due to depression that is easily treated with antidepressants. Or delirium. In delirium, there is a metabolic cause that is causing disturbance and confusion acutely, and when you treat the metabolic cause, the patient gets normal. After clinical evaluation, you do cognitive testing. In the cognitive testing, you perform certain tests like clock drawing test, mini mental state exam. In the mini mental state exam, you ask 30 questions from the patient, and the patient answers those questions like what year it is, what day it is. You tell them to spell a certain words backward, you tell them to count in a certain manner. Then you score the patient. If the score is less than or equal to 24, it means that the patient has dementia. How do you do cognitive assessment? I have talked about it in detail in my introduction of dementia video. This picture shows the diagnostic criteria for Alzheimer's disease: multiple cognitive deficits manifested by memory impairment, one or more of aphasia, apraxia, agnosia, or disturbance of executing functions. Significant impairment in social or occupational functioning, gradual onset and continuing cognitive decline. Symptoms not due to neurological, systemic, or substance abuse conditions known to cause dementia. Now, this is very important that if there is a neurological cause, if there is a systemic cause, or substance abuse is known, it means that this is likely due to secondary to neurological condition, systemic condition, or substance abuse. Alzheimer's disease is the disease which is unknown, which is most likely genetic, where you do not know the cause of memory loss. If you know the cause of memory loss, then this is not Alzheimer's disease. So you do clinical evaluation, you do the cognitive testing, you do tests, and you apply the criteria. Then you go ahead to the third part, the brain imaging. So clinical evaluation, cognitive assessment. In the brain imaging, you perform MRI. In the MRI of brain, what you can see is that there is medial temporal lobe atrophy, especially the hippocampus is involved. Changes on brain MRI takes time. So initially diagnosis is based on cognitive assessment and clinical evaluation. Now this is a picture showing normal brain, and this is a picture showing Alzheimer's disease patient. Look at the atrophy of brain in Alzheimer's disease. Look at this area. This area is the hippocampal area. Look at the normal healthy hippocampus and compare it with the atrophied hippocampus in this patient. And hippocampus is involved in short-term memory, therefore these patients experience short-term memory loss. This is another picture showing atrophy of the temporal and parietal lobes. Look at the atrophied brain. This is seen in Alzheimer's disease. Now, after doing clinical evaluation, cognitive testing, and brain imaging, another thing that helps you in the diagnosis are the CSF and blood test biomarkers. You do CSF test for amyloid beta 42, which is reduced in the Alzheimer's disease, and tau protein is increased. In the same way, if you test blood for plasma beta amyloid and tau protein, what you would see is there will be decreased amyloid beta and increased tau protein in the blood. That can also help you in the diagnosis. As I said, MRI changes take time. So initially, these tests can help you in the diagnosis of Alzheimer's disease. Another modality that is used for the diagnosis of Alzheimer's disease is the PET scan. And there are different types of PET scan. This picture shows amyloid beta PET scan, where it detects the amyloid beta presence in the brain. The upper three pictures show the normal brain. In the lower three pictures, you can see the increased intensity of the red portion, and this red portion actually shows the presence of amyloid beta plaques in the Alzheimer's disease patient. They give certain agents to the patient, and those agents are taken up by the amyloid beta protein that is present in the brain, and that lights up on the scans, and that light up scans show you the presence of amyloid beta protein in the brain. So this is called as a PET scan. Now, coming to the treatment of Alzheimer's disease, there are two aspects of the treatment of Alzheimer's disease. There is this pharmacological therapy that you do in these patients, and then there is this supportive care therapy. All patients of dementia ultimately need supportive care because there is nothing that can cure it. You have to provide supportive care till the end of their life. Alzheimer's disease is treated pharmacologically with certain medications that affects the acetylcholine, that increase the acetylcholine in the brain, because acetylcholine reduction results in Alzheimer's disease. So we try to increase the acetylcholine, or we use NMDA receptor antagonist, or we use A beta monoclonal antibodies. What are these? Now we are going to talk about that. First of all, coming to acetylcholine esterase inhibitors. Acetylcholine esterase inhibitors basically increase the acetylcholine by inhibiting the enzyme acetylcholine esterase that breaks down acetylcholine in the synapse. Therefore, it increases the acetylcholine that is present in the synapse and increases the brain stimulation, resulting in improvement of the symptoms. It includes rivastigmine, galantamine, donepezil, very important drugs that you need to memorize because these are very commonly tested on exams. A simple way to remember them is by the mnemonic go down the river. Go down the river. Now, when you are increasing acetylcholine in the brain, you are increasing stimulation, there are side effects, the acetylcholine side effects, the cholinergic side effects. These side effects can be seen as cholinergic crisis in these patients where there is bradycardia, slowing down of the heart, and it also can result in dizziness. Now, these parasympathetic side effects needs to be monitored, and whenever you are starting these drugs to the patient, always check the heart rate and obtain 12 lead ECG because it can result in heart block. Now coming to NMDA receptor antagonist, memantine. Remember, in neurodegenerative disorder, there is excess glutamate present in the synapse, and that excess glutamate causes neurodegeneration due to excessive excitation of the brain. This is opposite from acetylcholine, where there is less acetylcholine and less stimulation of the brain. Glutamate is overexcited in neurodegenerative disorder, resulting in neurodegeneration. So what we try to do in the treatment is that we try to block this glutamate effects by giving NMDA receptor antagonists like memantine that block the glutamate receptor, therefore prevent the progression of neurodegeneration in these patients. While on the other hand, we try to increase acetylcholine because that has a protective effect. So this is a bit contrasting, but this is something that you have to memorize. Side effects include confusion, hallucination, seizures, and constipation. Another important development in the treatment of Alzheimer's disease is A beta monoclonal antibodies, aducanumab. Aducanumab is a monoclonal antibody that has been recently introduced and that has shown to decrease the amyloid plaque deposition, amyloid plaque formation in these patients, preventing the progression of Alzheimer's disease. So these were the three main important domains that you need to remember in the treatment of Alzheimer's disease. The side effects of these monoclonal antibodies include brain edema. Now, the supportive care that you have to provide to these patients include that in the initial stages they will be having depression. For that, you have to give SSRIs. If these patients get agitated and psychotic, first of all, try to avoid giving antipsychotics to these patients, because the risks are much more than the benefits of giving antipsychotics to these patients. Try to do non-pharmacological de-escalation methods. But if those fails, what you can use is that you can use an SSRI for the treatment of agitation. While it will be surprising for you, citalopram has shown to reduce agitation in patients with Alzheimer's disease. So citalopram can be used, or you can use low dose atypical antipsychotics like risperidone or quetiapine in these patients. Now, it will be a common scenario in ward where the nurse would come to you and tell you that the Alzheimer's disease patient has stopped eating, and you would reflexively think of passing a nasogastric tube and start feeding. Since these patients have memory loss, ultimately they stop eating. Remember, do not put any nasogastric tube in these patients for feeding. This is a normal, natural process of death in these patients, where you just only provide comfort feeding. If they stop eating, you can simply provide comfort feeding with ice cream, custard, whatever they like with the hands. There are no dietary restrictions in these patients. Don't be very strict on diet for these patients. These patients should be given whatever they want to eat, and you can feed them by hand rather than passing NG tube. What if they don't chew the food? Even if you put food in their mouth and they don't chew it, now in that case you have to tell the family that it is a normal, natural process of death in these patients where they stop eating, and you should only provide comfort to these patients. It is not the food is not intended to provide any nutritional value. We have to just provide comfort to these patients. It's a normal, natural process, and let that normal, natural process go on in these patients. Also, avoid catheterization in these patients. In the supportive management, familiar home environment should be given to these patients. Regular exercise in the initial stages, proper sleep cycles should be given, and in the diet, don't be very strict on diet in these patients. Cognitive training, cognitive stimulation should be done to improve their cognition. And when in the initial stages of dementia, if the patient is diagnosed with Alzheimer's dementia, must do advanced care planning, must decide about how would they like a CPR or not, what will be the DNR status in these patients, because later on they will lose more memory and won't be able to make these decisions. The complications of Alzheimer's disease include aspiration pneumonia, a very important complication and a common cause of death in these patients. Because if you force feeding in these patients develop aspiration, malnourishment, and intracerebral hemorrhage. Before going to the summary, if you liked my video, please click on the subscribe button. If you want to support this channel, you can donate on Buy Me a Coffee. You can also check out my videos on ECG lectures, neurology lectures, emergency medicine lectures. The links of those videos are given in the description below. Thank you very much. We talked about what is Alzheimer's disease, we talked about the causes, we talked about the risk factors, what are neurofibrillary tangles, and what are senile plaques. We talked about reduced cholinergic stimulation, the clinical presentation, the how apraxia agnosia develops in these patients, the behavioral depression in the initial stages, agitation in the later stages. No single diagnostic test is there. A set of cognitive clinical evaluation, cognitive testing, brain imaging, and biomarkers is used for the diagnosis. The brain imaging findings, PET scan, the diagnostic criteria, and pharmacological interventions that are done in these patients. Supportive care is done in these patients, when to stop feeding, and the advanced care planning in these patients. The complications, aspiration pneumonia being the most common one. If you like my video, please click on the subscribe button and make sure to check out my other lectures on my channel. Thank you very much.